Hello everyone. In today's presentation, I am talking about the relationship between periodontitis and cardiovascular diseases, or in plain language, between gum and heart disease. Cardiovascular diseases are responsible for 17.9 million global deaths per year, of which 3.9 million deaths in Europe. This is 45% of all deaths and is comprised of either stroke, hypertension leading to heart failure, or ischemic heart disease. 45 to 50% of the world population suffers of periodontitis, with 11% of this being severe form of periodontitis. Gum disease is the sixth most common human disease in the world. Major traditional risk factors for cardiovascular diseases are lifestyle factors, most importantly tobacco smoking, dyslipidemia, which means abnormal amounts of lipids in the blood, hypertension, and altered glucose metabolism. These factors are also related to diets high in saturated fats, excess salt, and refined sugars, as well as obesity. There is significant body of evidence supporting independent associations between severe periodontitis and cardiovascular disease in various different populations. The mechanism for these associations is believed to include bacteremia and the associated inflammatory reactions, including elevations in C-reactive protein and oxidative stress. So, to make it simple to understand, the bacteria from the gum disease sites in the mouth can translocate elsewhere in the body, causing inflammation, triggering other events such as heart failure. At present, it appears that the periodontitis can be a modifiable risk factor for cardiovascular disease. A modifiable risk factor is a factor that can change, a factor that we can improve. The 2012 consensus report by European Federation of Periodontology and the American Academy of Periodontology concluded that there was consistent and strong epidemiological evidence that periodontitis presented an increased risk of atherosclerotic cardiovascular disease. The consensus also concluded that the effect of periodontitis on heart disease was biologically possible through translocation of circulating oral bacteria. This translocated microbiota may directly or indirectly lead to systemic inflammation with effects of development of cardiovascular disease. The most recent consensus reports by European Federation of Periodontology and the World Health Federation, held in Madrid in 2019, demonstrated that there is evidence from studies that periodontitis patients exhibit significant endothelial dysfunction. There is robust evidence from the epidemiological studies for a positive association between periodontitis and coronary heart disease. Evidence was also available from epidemiological studies to show a positive association between periodontitis and cerebrovascular disease. The overall available evidence has demonstrated that bacteremia results from daily life activities such as, for example, toothbrushing, chewing, flossing, and professional oral interventions like probing, scaling, and tooth extractions. It has been demonstrated that the magnitude of the oral bacteria entering blood circulation is greater among the patients suffering of gum disease. The authors of the consensus report looked at the limited evidence suggesting that cardiovascular disease drugs such as statins may have a positive anti-inflammatory effect on periodontal health. However, taking all the available evidence from the existing trials and systemic reviews, the conclusion was that systemic statins intake does not enhance the outcomes of periodontal therapy. In relation to timing of the periodontal treatment, it was found that delivering full-mouth periodontal treatment within 24 hours triggers a 1-week acute systemic inflammatory response. This inflammatory state is not seen when periodontal treatment is carried out in several separate sessions. This was documented by Professor Graziani and colleagues in 2015. The consensus group looked at the available evidence and also concluded that delivering periodontal treatment is safe in relation to cardiac risks in patients with cardiovascular disease. The consensus group also found that the available evidence does not support discontinuation of antiplatelet therapy before dental procedures, regardless of the type of antiplatelet therapy or the type of dental procedures, for example, single or multiple tooth extractions, non-surgical and surgical periodontal treatment, and dental implant procedures. Patients taking oral anticoagulant therapy, such as vitamin K antagonists, do not seem to be at increased risk of bleeding compared to patients who discontinue oral anticoagulant therapy when undergoing dental extractions, minor dental procedures, and implant treatments. Local hemostatic agents are effective in postoperative bleeding. Now, for professionals treating patients with cardiovascular disease, the current evidence-based recommendation is to advise the periodontitis patients that they could be at higher risk of cardiovascular disease, such as a stroke or myocardial infarction. These patients must be advised to modify risk factors like smoking, exercise, excess weight, blood pressure, lipid and blood sugars, periodontal treatment, and maintenance. Patients should be advised to consult their physician to control these non-dental modifiable risk factors if needed. Comprehensive periodontal evaluation and personalized oral health education should be provided to all periodontitis patients. Patients with a diagnosis of cardiovascular disease should be placed on a preventive periodontal care program, for example, 3 monthly hygienist visits, even if they are not suffering of periodontitis. In patients with established cardiovascular disease, regardless of the severity of the cardiovascular disease or medication, non-surgical periodontal treatment should be carried out in several 30 to 45-minute sessions with an aim to minimize the acute systemic inflammation. Surgical periodontal and implant treatment should also be provided in short, less traumatic sessions. The 2019 consensus report also recommends that in patients suffering of hypertension, patients' blood pressure should be measured before the surgical intervention, and if blood pressure is high, above 180/100, the surgery should be postponed until the patient's blood pressure reaches the optimum levels. In general, periodontal and implant surgical procedures pose a low to medium risk of bleeding. Hence, antiplatelet and anticoagulant drugs should not be stopped, and if in doubt, patient's physician should be contacted before planning the surgical procedure. Discontinuation of anticoagulant therapy should only be advised after fully discussed and agreed with the medical professional prescribing the anticoagulant therapy. Local hemostatic agents such as oxidized cellulose absorbable gelatin sponges, sutures, tranexamic acid mouthwashes, comprehensive gauze soaked in tranexamic acid should be used, and dental surgeons must also pay attention to the confounding effects of these with oral anesthetic solutions. The general advice for patients are brushing with either manual or electric toothbrush twice a day, use of interdental brushes to clean the spaces between the teeth, and where not possible, use of dental floss. Gum disease may not be present with any symptoms, hence the importance of regular checkups as part of a cardiovascular disease maintenance program. Patients should look for signs of gum disease, such as red or swollen gums, spaces between the teeth, hard deposits on the teeth, longer looking teeth, foul taste, bleeding from the gums, loose teeth, and seek advice from a dentist if any of these signs are present. Finally, for the patients watching this video, please brush your teeth twice daily for 2 minutes and use interdental brushes or dental floss to clean in between your teeth at least once a day. Visit your dentist and hygienist at least twice a year. If you suffer of any type of cardiovascular disease, please let your dentist know and seek a comprehensive assessment of your gum health. Thank you for watching this, and I hope both colleagues and patients found this video useful. I would like to thank Professor Mariano Sanz and his colleagues for making this knowledge available to us through this consensus report.